الذين آمنوا بآياتنا وكانوا مسلمين ادخلوا الجنة أنتم وأزواجكم تحبرون يطاف عليهم بصحاف من ذهب وأكواب وفيها ما تشتهيه الأنفس وتلذ الأعين وأنتم فيها خالدون وتلك الجنة التي أورثتموها بما كنتم تعملون لكم فيها فاكهة كثيرة منها تأكلون. صدق الله العظيم.
Much, Brother Yahya. So we are going to, without further ado, go straight to the session, inshallah. Daktari, are you logged in?
Assalamu alaikum. I'm in, but I'm unable to share my what do you call the slides. Okay, now I think I can. Let me just try. Yeah, so
So as Daktari shares, for those of you who don't know Dr. Hassan, Dr. Hassan is a consultant cardiologist. He's been able to take us through the first session on introduction to ECG. He's also, mashallah, he's done a bit of work around medicine. He's been serving as a county physician in Isiolo for 6 years. He's currently working as a physician cardiologist in Nairobi South Hospital and also a visiting consultant in Isiolo Hospital. He's done his cardiology fellowship in Aga Khan. Currently, he's undertaking interventional procedures at KNH Cath Lab. So we have one of the best around. So we are privileged to actually have you, Daktari. Thank you so much. I think we can now start.
Okay, thank you so much for that kind introduction once again. Just a quick recap of last time, so that probably some few guys may have missed, but inshallah, as promised by the vice chair, one of these fine days we'll have a session, physical session, because when it's physical, it's actually better, and it's more interactive rather than this virtual thing. And in our physical meeting, I'll try to bring different ECG examples of patients we have. We have a lot in the archive, so that when you see, a real ECG, it sticks better, and we'll discuss one of these every wave one by one on our physical ECG. But the first thing when you're interpreting ECG, we said you check for the name, just the usual thing is a good trend, especially right now, you guys where you are. Don't go straight to shortcut. If you're told, okay, read this ECG, don't straight go and say there is no ST elevation or something like that. Just have the habit of trying to learn, this is the ECG of so and so, taken on this particular date, indication is this. If there's any previous ECG, try to compare, it's very important. We explained why. Then the next thing you look at is calibration. Calibration, I mentioned to you, it's usually at the bottom of the ECG paper. That's where it's written, and it gives you two indices. One is the speed of the paper, 25 millimeters per second is the standard 12-lead ECG. But you can have 50, you can have 100, especially 100 we use it, or even sometimes 200 millimeters per second, we use it in electrophysiology studies. The other index which is usually there is 10 millivolt per millimeter, and that is the height of the waves, because that's what we'll use when we are talking about LVH, RVH, right ventricular hypertrophy ECG criteria. We'll be adding up that voltage, the amount of deflection below or above the isoelectric line is what we call, basically that's what it denotes. After you have confirmed your calibration, then this is how you approach. You start with the rate, which you have seen quickly. And then I told you the rate, basically, there are several ways of determining it. Basically, you want to know whether it's regular or irregular. But generally speaking, if you are short of time and you really want to calculate rate very fast, just go down to the rhythm strip, usually that lead ECG, which is down there, and count the number of QRS complexes in that particular strip and multiply by 6. That will give you the rate very fast. But if you want to determine the exact rate, you the number of, 300 by the number of large boxes between two QRS complexes, or 1500 divided by the number of small boxes. Then we said, so this is what I was talking about. These are the indices. The horizontal time basically tells you about time. The vertical tells you about voltage. Then we talked about the rate, which I've just mentioned. Like, for example, if you go to this lower box, I can just count the number of QRS complexes multiplied by 6, or you can count the number of R between number of large boxes between 2 QRS complexes and divide that by 300, or you can count the number of small boxes between 2 large QRS complexes and divide that 1500 divided by that. And then that's how you calculate the rate. And the rate, if it is the normal, is between 60 to 100. If it is below 60, we call it bradycardia. If it's more than 60, we call it tachycardia. If it's more than 100, we call it tachycardia. After you have calculated your rate, the next thing you will go to now is to determine your rhythm. And the rule for the rhythm is very simple. Let me go straight to the rhythm. This is just a reminder of what we did last time. The rule of the rhythm is 3 things. Number 1, and basically most of the time you concentrate on lead 2. That's where you will concentrate on. So one of the things you like to do is, number 1, is every QRS preceded by P wave? That is criteria number 1. Criteria number 2 is if the P waves are upright, meaning they are above the isoelectric line, just like is demonstrated here. So this is the isoelectric line. I don't know if you can see my arrow. If it's above it, we call it a positive P wave. If it is below it, we call it a negative P wave. Now, if, for example, it is not positive, then that is not sinus. So rule number 1, every QRS must be preceded by a P wave. Number 2, the P wave must be positive. And the third rule is 1-to-1 ratio, meaning if you have 1 P wave, it's only 1 QRS. 1 P wave, 1 QRS. Because you may be having a positive P wave in lead 2, and you may have 2 P waves followed by 1 QRS. That's not sinus. So if those 3 criteria are fulfilled, then you have a sinus rhythm. Anything outside that, we call it arrhythmia. Whether it is ventricular tachycardia, whether it's atrial fibrillation, it doesn't matter. So anything outside that is what you call arrhythmia. And all these we'll see one by one. All these things are called arrhythmias because they are outside the rhythm. A very good example is the first one, which is called sinus arrhythmia. Is a normal physiological process, but because it doesn't fulfill that criteria, that's why it is called sinus arrhythmia. And these are examples of rhythm disturbances, which we'll be able to see in the subsequent topics. The third thing we discussed is axis. And axis, as I told you, the 2 most important leads you need to look at is lead 1 and AVF. If both of them are positive, and here positive, I mean the electric or the deflection is above the isoelectric line. So if both lead 1 and AVF are positive, then your axis is normal. If lead 1 is negative, you have right axis deviation. If lead AVF is negative, you may have an left axis deviation, but it's good to confirm with lead 2, so that if both lead 2 and AVF are negative, then you have left axis deviation. And the axis deviation here is not just to confirm the diagnosis. This patient has right axis deviation. No, you need to know what are the causes or the differential diagnosis of right axis deviation and left axis deviation, which we'll be able to discuss in details. And this is what I told you. If lead 1 is positive, AVF is positive, the axis is normal. If, however, lead 1 is negative, then you have right axis deviation. If lead 2 or AVF is negative, then it's always good to look at lead 2 together. If both of them are negative, then you have got left axis deviation. So after we have done rate, rhythm, and axis, the next thing to do is to look at individual waves. Previously, before some few years ago, the approach used to be different. You do rate rhythm axis. After that, you look for chamber enlargement. You look for ST segment elevation or depression like that. But right now, the better way to approach is you start from the first letter and go horizontally all the way and assess each wave one by one. And you'll answer two questions. What does that wave represent? Three questions, sorry. Number one, what does that wave represent? Number two, what is the normal of that wave? And number three, what is abnormal? And if it is abnormal, what are the causes? So if you know the differential diagnosis for those three questions or the answer to those three questions, you are done with the waves. And today we'll start with the P wave. So question number one is, what does P wave represent? P wave basically represents atrial contraction, period. So anything to do with the atrium, whether it is atrial fibrillation, atrial enlargement, atrial tachycardia, anything to atrial flutter, anything to do with atria, atrial ischemia, whatever it is, you only concentrate on the P wave. And this is the advantage of approaching the ECG on a wave by wave basis. That way you will not miss anything. So if I am interested in the atria, whether it's atrial enlargement, whatever it is, I'll only look at the P wave. So P wave, what does it represent? We'll answer our three questions. Question number one was, what does the wave represent? And the answer is atrial contraction. Question number two, what is the normal P wave? That is the second question. And the normal P wave, there are a lot of details here, but I just want you to remember 2 points. Point number one. So it is usually 2 by 2. In other words, it is wider by 2 small boxes and taller by 2 small boxes. Anything outside that is an abnormal P wave. That is number one. That is the normal feature of P wave. The second normal feature of P wave, it is usually upright in all the leads. All, except probably in V1, which we call it biphasic. I will repeat that. It is usually positive. Positive here means it is above the isoelectric line. The deflection is above. And therefore, it is supposed to be positive in all the leads, except probably in V1 or lead 3, whereby it is biphasic. Biphasic means it has a positive deflection and a negative deflection. I will show you in the subsequent slides. So all these other things, forget about, which is written in these slides. Question number one, what does it represent? Normal atrial contraction. What is normal P wave? It is 2 by 2, 2 small boxes wide, 2 small boxes tall. If it is wider than 2 small boxes, is an abnormal P wave. If it is taller than 2 small boxes, it is an abnormal P wave. Number three, it is usually positive in almost all the leads, except 1 and lead 3 probably, which is biphasic. If these two criteria are fulfilled, then you wave, and therefore is normal. So just to give you an example, if the P wave is taller than 2 boxes or 3 small boxes, we call it tall peaked P wave. And it means the right atrium is enlarged. If the P wave is wider than 2 small boxes, we call it a wide P wave. And a wide P wave represents left atrial enlargement. Number three, if the P wave is not there, is completely absent, it means it is not coming from the sinoatrial node, it is coming from somewhere else, it's abnormal, and if it is absent, you can't see a P wave, the diagnosis is atrial fibrillation. If you see a lot of P waves, zimeshikana, zimefuatana, very many, like a sawtooth, that is atrial flutter. If there is P wave, that means there is a deflection before QRS, but that P wave is not positive, it's negative. It's looking down. It means it is coming from the lower part of the atrium. It's not the normal route, which is the sinoatrial node. So those are the 4 pathologies of P wave. I'll go back. The first question is, what does P wave represent? The answer is atrial contraction. The second question is, what is normal P wave? It is wider by 2 boxes and taller by 2 boxes. It is positive in all the leads. What is an abnormal P wave? 1, if it is wider than 2 boxes, in which case it represents left atrial enlargement. If it is taller than 2 boxes, in which case it represents right atrial enlargement. If it is absent, in which case it represents atrial fibrillation. If it is there, but there are very many as mexicana, like sawtooth, it is atrial flutter. If it is negative, it means it's not coming from the left atrium. I mean, the right atrium, the sinoatrial node is coming from somewhere else, maybe around the junction, the AV node or something like that. So then the subsequent slide is a summary of what I've already mentioned. So whenever you want to talk about the atrium, it means you are discussing basically the P wave. P wave basically means the atrium. So if you have got an atrial enlargement, increase the amplitude or increased width, it tells you left or right atrial enlargement and dilatation. If it is inverted, it means ectopic. It is not coming from the sinoatrial node. It's coming from somewhere else in the atrium. If it is absent, most likely you're dealing with atrial fibrillation, but these other differential diagnoses are also there. Sinoatrial block and AV junctional arrhythmia, which is a bit detailed for you guys. Just remember, an absent P wave is atrial fibrillation until proven otherwise. Now, more details here. This is the normal P wave. So I told you in all the leads, as you can see, lead 2, lead 3, AVF, V3, V6, V5, V4, everywhere it's positive. It is only negative in one lead, which is AVR. And AVR, by the way, it's not only P wave. P wave, QRS, T wave, everything is negative in AVR. And it's one of the tricks people use to cheat you whether an ECG is abnormal or not. So whenever you do an ECG, you look at AVR. AVR, everything must be negative. As you can see here, the P wave is negative, QRS is negative, T wave is negative. If you see an AVR is positive, the P is looking up, the QRS is looking up, it means somebody has exchanged the leads. And this could be a tricky question. It can come in OSCE, sport, something like that. So always look at lead AVR, whether to confirm to you whether the leads have been placed very well or not. So if all the leads, I mean, all the waves in AVR are positive, then that leads have been misplaced. They have exchanged lead 1 and AVR. Recently, I had a patient in the ward and the ECG was done like that. So when you look at the ECG, you think there's ST segment depression in some of the leads. Kumbe, there was, they exchanged the leads. And when we did the right way, she had a pathology, but it's not what we suspected earlier. Number 2, I told you the only lead which the P wave can be biphasic. Biphasic means it has a positive deflection and negative deflection is in V1. Otherwise, all the other leads, except in AVR, P wave must be positive for you to call this is a normal P wave. If it is not positive, then it's an abnormal P wave and it represents a pathology. Now, I have told you that if the P wave is taller than 2 small boxes, we call it tall peaked P wave. We call it, we represent right atrial enlargement. And when you look at the differential diagnosis of right atrial enlargement, almost all of it is caused something related to the pulmonary system, like pulmonary hypertension, pulmonary stenosis, pulmonary regurgitation, right ventricular hypertrophy, tricuspid regurgitation, tricuspid stenosis. Basically, is in the outlet of the right atrium. And because most of the pathology comes from the lung, that's why we call it P pulmonale. So P pulmonale is a tall peaked P wave, most likely to be seen in lead 2, and is as a result of pulmonary pathology, and it represents right atrial enlargement. In other words, the P wave is taller than the usual dimension, which is around 2 small boxes. Left atrial enlargement, maybe I forgot the slide, is you look at usually most of this time, whenever you are looking at the P wave, concentrate on lead 2. You remember I told you lead 2 is found at the bottom. It usually tells you that that's the rhythm strip. So P wave, whenever you are assessing P wave, concentrate on lead 2. You look at the depth, I mean the amplitude, you look at the width. If the width is tall, I mean wider than 2 millimeters, or which is 2 small boxes, then we call it a wide P wave. And most likely it represents left atrial enlargement. And because most of it is caused by the mitral valve and so on and so forth, like mitral stenosis. So left atrial enlargement is caused by mitral stenosis, mitral regurgitation, so on and so forth. That's why it's called P mitrale. So P mitrale, it's a broad, wide, notched. Hello? You can hear me?
The previous slide, the P mitralia, I saw it in the previous slide, please.
Yeah, this one. Although this is represented in lead 1, the most important thing is, let me see if it's not very clear. I wanted to discuss the waves, then I give you real life examples, but usually we concentrate on lead 2. I don't know if I'll be able to enlarge, but basically this is P wave, and you count the number of small boxes from the beginning to the end. If it is more than 2 small boxes, then you call it a wide broad P wave. A wide broad P wave in lead 2 represents left atrial enlargement, and most of the pathologies as a result of the mitral valve, hence the name P mitralia. So I'll summarize P wave because we are done with it. Question number 1, what does it represent? Atrial contraction. Question number 2, what is the normal P wave? It's usually 2 by 2, the width and the amplitude, and it's positive in almost all the leads, except in V1, in which case it's biphasic. What is the abnormality? It represents 4 pathologies. 1, it is either tall, in which case it represents right atrial enlargement, we call it P pulmonale. 2, it is broad, in which case we call it P mitrale, it represents left atrial enlargement. 3, it is absent, and it represents most likely atrial fibrillation until proven otherwise. And number 4, it is inverted, meaning it's not positive. So that means there is an ectopic focus that is producing the P wave, which is not the sinoatrial node, and that's why it's negative. So that is for P wave, and I'll be able to show you examples once we are done with all the waves. If you have any question, you can keep it until the end of the topic, then we'll be able to discuss. The next thing, before I go to the PR interval, I want to go to PR segment. Or let me just continue the PR interval. So we have done with the P wave. Our P wave, if you can see my arrow, was from here to here, which was representing the atrial contraction. Now the next thing is the PR interval, and there's a difference between interval and segment. Interval is time. Segment is just a region. So the PR interval is from the beginning of the P wave to the beginning of the QRS complex. And as you can see, it represents a large area because it contains the P wave, and there's this region which we call the PR segment, which you will see later on what it represents. And because it's an interval, we measure in terms of time. So it's from the beginning of the P to the beginning of the QRS complex. And you remember we said the horizontal line represents time. The small box is 0.04 seconds. And I think I told you mathematical how we arrived at that figure. The large boxes, because it contains 5 small boxes, is 0.2 seconds. Now, a normal PR interval from the beginning of the P wave all the way to the QRX should not be bigger than 1 large box. In other words, the time should not be more than 0.2 seconds, because 1 large box is represented by 5 small boxes, each one representing 0.04 seconds, so times 5 gives you 0.2 seconds. If it is bigger than 1 large box, we call it prolonged PR interval. And that is when we'll go into the topics of blocks. 1st degree AV block, 2nd degree, 3rd degree, like that. Okay, so the PR interval tells us a lot of information. 1, atrial repolarization, depolarization, atrial repolarization, and the time by which electricity is kept at the AV node. So this region between when the P is ending up to the QRS, which is called the PR segment, contains the AV node and the His bundle. So all this area from the beginning of the P wave all the way to the beginning of the QRS complex, which is the PR interval, will tell you the amount of time electricity travels from the atrium until it is held at the AV node before it's transmitted to the ventricles. And it's a very important segment. That is the area that tells us the coordination between the atria and ventricle. Because later on, when we'll discuss the blocks, for example, AV blocks, like 3rd degree AV block, there is no relationship. The PR on their own, the QRS on their own, we call it AV dissociation. So the PR interval, it's from the beginning of the P wave to the beginning of the QRLs, and it tells us the atria activity, whether depolarization and repolarization, all the way up to the AV junction. So the AV node is included, the His bundle is included, the left atrium is included, the right atrium is included. So it's a large interval. And you can have two things. It's either prolonged or shortened. Generally speaking, shortened, the one I want you to remember is only one condition: the causes of shortened PR, WPW. Forget about all these other things, pheochromocytoma, hypertension, tachycardia, all those things they shorten. But the most important one is WPW, what you call the accessory pathway pre-excitation syndromes. The one which is more important, which we need to know, is the AV blocks, which we'll discuss one by one, all the way from 1st degree to 3rd degree. And a very good example is here. This is the P wave, this is the QRS. And our PR interval starts from here, where my arrow is, the beginning of P wave, all the way to the beginning of the QRS complex. And this is more than one large box, because we say the normal is up to one large box. Anything more than one large box, the PR interval, we call it prolonged PR interval. And the most important differential diagnosis is AV blocks. But other things like Lyme disease, because it causes conduction defects, things like, for example, beta blockers, athletes, people who are bradycardic, they can have a prolonged PR interval. The more prolonged it is, the more likely the patient will be symptomatic. As far as shortened is concerned, and the shortening here is not actually a physical shortening. It will discuss the pathophysiology and the pathology of WPW, but what happens is that when the P, because of the accessory pathway, that waiting period at the AV node is bypassed, because there's an accessory pathway. Because I remember I told you when we were discussing the conduction pathway, the only electric connection between the atria and ventricle that's allowed is the AV node. There should be no any other electric connection. For people who have WPW, they have an abnormal connection, so that from the sinoatrial node, you bypass the AV node and you send electricity down to the ventricles very fast. Because of that, there is this sharp rising, what we call the delta wave. And that delta wave, because of that rapid transmission of electricity, because of the accessory pathway, is what causes a shortened PR interval. Otherwise, it is not because the PR is actually shortened. It's just that because of the accessory pathway, that rapid transition creates an ECG picture as if the PR has been shortened. So the commonest cause of shortened PR interval is WPW. The others are not very important, but the most important one is WPW, which we'll discuss in more details. So I'll summarize again PR interval. It represents the duration of electric flow from the beginning of the P wave all the way to the beginning of the QRX complex. The normal value, because we are answering the three questions. Number one, what does it represent? It represents atrial depolarization, repolarization, and electric flow up to the AV junction. And it starts from the beginning of P wave to the beginning of QRS. Our second question is, what is the normal variant? The normal variant is one large box. Usually, it is from 3 small boxes to 5 small boxes, basically one large box. If it is outside one large box, we call it prolonged PR interval. If the PR interval is prolonged, the most important differential diagnosis is AV blocks, which we'll discuss in details. If the PR interval is smaller than 3 small boxes, then we call it shortened PR interval, and the most important differential diagnosis is WPW. The next segment is called the PR segment. Here we use the word segment because it's not time. Now this area is very, very important, especially for the electrophysiologist, when they're studying what you call EP studies, when you want to ablate, when you want to understand flow, electricity flow through the His-Purkinje fiber system, so on and so forth. This is a very important segment. And when you're in the EP lab, you can actually zoom and magnify this place so much. You can see the His bundle, you can see the AV node, you can even separate between the 2 branches, bundle, etc., etc. But for us at this level, the most important differential diagnosis for you guys is pericarditis. Pericarditis causes PR segment depression. They like asking, especially in MCQs and sometimes in sports. So if a patient has got features suggestive of pericarditis, there are other ECG important parameters for pericarditis, but just for the purpose of MCQ, remember, pericarditis is a common cause or is the main cause of PR segment depression. In other words, instead of a straight line, you'll find it depressed a little bit, going down like this. Another cause is atrial infarct or atrial ischemia, which is not very important for you. So the most important thing is, what does the PR segment represent? It represents the AV node and the His bundle. What is the normal? It's supposed to be flat, and it's not supposed to be longer. Usually it's considered as part of the PR interval. What does it represent in terms of pathology? If there's PR segment depression, and you have also widespread ST elevation as part of the other criteria for ECG for pericarditis, then it confirms to pericarditis. Okay, so it's the end of P wave to the beginning of the QRS. It's usually isoelectric, and it tells you, if it is displaced, it tells you two things: pericarditis and atrial infarction. The one I want you to remember mostly is acute pericarditis, because the atrial infarction, most of the people don't even know, and it's only cardiologists who bother with it. So far we have covered the P wave, we have covered the PR interval, we have covered the PR segment. And every segment and wave, when you are discussing, ask yourself those three questions. What does the wave represent? What is the normal of that particular wave? And what is the abnormality, or what is the pathology? Okay, now we go to the most important complex, which is called the QRS complex. And we'll still answer in three questions. Question number one, what does it represent? It represents ventricular depolarization. And depolarization, from what you remember, is basically electric cations, exchange, where sodium goes in, potassium comes out, and the myocardium contracts as syncytium. The word we use is syncytium because it's supposed to contract as a whole unit. If it doesn't contract as a whole unit, it causes what you call inefficient pump, and that's one of the causes of heart failure, and that's what we treat with drugs, not drugs, devices like CRT, which is a special pacemaker. So ventricular depolarization is represented by the QRS. Now, it does not necessarily mean that every ECG must have QRS. No, you can have different patterns. You can have RS, you can have QS, you can have QR, you can have QR, you can have QRSR prime, like that. The most important thing you need to remember, the first negative deflection after the P wave is called Q. Any negative deflection that comes after is called S. Any positive deflection that comes after Q is called R. So you can have R, R prime, R prime 2, like that. You can have S, S prime 2, S prime 2, like that. So the pattern changes according to the lead. If I take you behind Kidogo like this, for example, these are various leads. This is V1. This QRS is different from this QRS, which is different from this. Like here, the R is small, the S is deep. Like here, for example, as you go here, R is tall, S is small. Here you may see Q wave. For example, here you may see Q wave, you may not see in another lead. So the pattern changes, but the most important thing is, what does it represent? It represents ventricular depolarization. Now, when we talk of what is normal QRS, there are three important points. Number one, duration. Duration means from where the QRS began until where the S is finishing, this period in between. Here we use the word QRS duration, and it's very, very important, because if you have a narrow QRS, it means the electricity is coming from the above ventricle. If the QRS is wide, and wide here I mean bigger than or wider than 3 small boxes. In other words, the normal QRS should be smaller than or equal to 3 small boxes. From the Q to the S, this opening, the opening inside the QRS should not be more than 3 small boxes. If it's more than 3 small boxes, we call it wide QRS. And wide QRS is a whole topic on its own, what we call the wide QRS tachycardias, wide QRS complexes. And it represents a lot of important pathologies, arrhythmias, some of them very lethal, like wide QRS complex tachycardias, ventricular tachycardias, polymorphic tachycardias, so on and so forth. That is the first question. So I'm answering question number 2 which is our usual questions of the waves. Question number 1 was, what does it represent? Ventricular depolarization. Question number 2 is, what is the normal QRS? Now, question number 2 here has 3 answers, A, B, and C. A is, what is the duration? And the duration is not more than, I don't want you to remember all these detailed seconds, forget about it. Just remember, it should not be more than 3 small boxes. Question number 2B is, what is the size? Now, this amplitude will depend on the lead. Is it chest lead or is it limb lead? That we'll discuss when we'll talk about chamber enlargement, because the amplitude will tell us about either right ventricular hypertrophy or left ventricular hypertrophy. And I will tell you which leads to look at. Right now, we are just looking at the normal QRS. What does it represent? It represents ventricular depolarization. The normal duration is supposed to be less than 3 small boxes, and the amplitude is not supposed to be more than 5 millimeters, which is basically 1 large box, or in the chest limb leads is not supposed to be more than 10 millimeters, which means 2 large boxes. If it's more than that, then there is a pathology. And the pathology here we are talking about is chamber hypertrophy. In the ventricles, we use the word hypertrophy. Left ventricular hypertrophy, right ventricular hypertrophy. But in the atria, we use the word enlargement or dilatation. The number C of question number 2 is what we call the Q wave, which is a very important when it comes to myocardial infarction, ischemia, ischemic heart disease, and coronary artery disease. Now, the normal Q wave, there is a normal Q wave. It's usually very, very small. It's a small deflection. If you see a Q wave that is deep, that is competing with the R wave, then that Q wave is pathology. So you can have a normal Q wave in a normal patient. But the only time you will say pathological Q wave is number 1, if it's deep or taller than a third of the corresponding R wave, or if after the P wave you go directly down, there is no R, what you call the QS pattern. When you see those two, then you talk of pathological Q wave. So what does the QRS complex represent? Now we are talking of the third question. Question number 1 was, what does it represent? Ventricular depolarization. Question number 2 is, what is the normal variant, which we divided into 3, duration, amplitude, and the Q wave. Question number 3 is, what does the QRS complex represent in terms of pathology? Number 1 is wide. If it is wide, most likely we are dealing with electricity originating from the ventricles. It's not coming above the ventricle. So later on, when we discuss tachycardia and arrhythmia, we will divide them according to the QRS complex. So you will hear of narrow QRS, wide QRS. If it's wide QRS, it's coming from the ventricles. And therefore, if you have a wide QRS, one of the most important differential is what you call the bundle branch blocks. Left bundle branch block, right bundle branch block, and the hemi blocks. The second point is in terms of voltage. Is the QRS tall or short? If it is very short, what you call low QRS or low voltage, it represents a lot of things. But the 2 most important ones I want you to remember is pericardial effusion and hypothyroidism. So the 2 commonest causes of a short or a small QRS complex is usually pericardial effusion and hypothyroidism. Although even obesity, because of the large subcutaneous fat, the electricity transmitted from the heart, the ECG may not be able to pick. You may also get short QRSs. But the 2 most important pathologies is hypothyroidism and pericardial effusion. If the voltage this time, instead of being short, is too tall, that means when you open the ECG, there are waves everywhere, very tall ECG waves, then you think of 2 conditions. Either there is chamber hypertrophy, whether because of hypertension, whether because of aortic stenosis, whether because of hypertrophic cardiomyopathy, whether because of pulmonary hypertension, whether because of congenital heart diseases that cause like cor pulmonale, whatever that cause right ventricular hypertrophy. Basically, there is chamber enlargement. The walls of the ventricles is thick, depending on which voltage is high. If it's V1, if it's V5, V6, and we'll come to the chamber enlargement. Okay? We'll come to the chamber enlargement. So I'll repeat, The pathology is either the duration is actually an answer to these three. Either the duration is enlarged, in which case we talk of bundle branch blocks, or the amplitude is either increased or reduced. If it is increased, we talk of hypertrophy. If it's reduced, the two most important differential diagnoses, pericardial effusion and hypothyroidism. So if you bring me an ECG and I see low electric voltage, I'll start asking myself, is this patient obese? No. Is the patient hypothyroidic? Yes or no. Does the patient has pericardial effusion? Yes or no. Of course, all these ECG findings, you will tie with your clinical history, physical examination, and the other parameters the patient presented with. The chamber enlargement criteria, I would like to jump right now so that we finish the waves and we'll come to the pathologies one by one. Now, after the QRS complex, which we have talked about as ventricular depolarization, there is another important segment which you call the ST segment. Just like the PR segment, which represents atrial repolarization and so on and so forth, this one is specifically for the ventricle. And this segment is very important when it comes to coronary artery disease. So when you are talking of MI, unstable angina, ischemic cardiomyopathy, coronary artery disease, this is the segment you will concentrate. Just the way I told you, when you're talking of atria, you concentrate on the P wave. When you're talking of the ventricle, you concentrate on the QRS. When you're talking of duration and electric transmission, you concentrate on the PR interval. So the ST segment is specifically meant for ischemia. The pathophysiology, why this region, we can go to the details if you guys want, but right now is not the time for it. But you can really understand why and what is responsible for ST segment elevation, what is responsible for ST segment depression, and so on and so forth. So ST segment is specific for ischemia, infarction, and coronary artery disease. There is a region called the J point, which you will hear the cardiologists sometimes arguing about it, but it may not be very important for you guys right now. So what does the ST segment represent? Again, I go back to our three questions for every wave. What does it represent? It represents the beginning of ventricular repolarization. In other words, the ventricles have contracted and now they are relaxing. The exchange of ion now is coming back to normal. The membrane potential is coming back to its resting position. So the beginning of ventricular repolarization is represented by the ST segment. What is the normal ST segment? It is supposed to be horizontal. It's supposed to be flat, what we call isoelectric. And we usually measure it according to the TP. TP means the T which is next to this ST segment and the next P level. So it's supposed to be isoelectric. It's not supposed to be either up or below the T wave. However, you may see some small ST segment elevation of depression, which is a normal variant, which I will call it early repolarization, is very common, especially if a young man between the age of 18 to 35 come to you, they have chest pain, you do their ECG, you may see this ST segment elevation from V1 to V4. That is not ST segment elevation unless the patient has typical angina. That is called early repolarization. Is a normal phenomenon that happens in young people, and we call it early repolarization, which we'll talk about it later. So the normal variant is usually isoelectric, but you may see small elevation in the limb leads and the chest leads. And the criteria for ST elevation we'll discuss more when we are talking about STEMI and SES, because there's a whole chapter I dedicated to acute coronary syndrome ECG. The criteria for limb leads and chest leads are different. Usually for the chest lead is smaller and the limb leads is usually higher. Oh, sorry, the other way around, the limb leads is lower. So in the same ST segment, you can have, so if I go back, I will answer the first question. What does it represent? The beginning of ventricular repolarization. What is the normal ST segment? Isoelectric with a slight elevation or depression in some patients. Now, what does it represent? You can have either elevation or depression. And the depression and elevation, it's in relation to the isoelectric line, which is represented by the TP. So you draw a line that connects T and P at the bottom. That will be your isoelectric line. If the ST segment is above that, we call it ST segment elevation. If it's below that, we call it ST segment depression. ST segment depression almost always represents ischemia, but there are very many other differential diagnoses. But the thing you should never miss is ischemia. ST segment elevation is also caused by many things. In fact, there's a mnemonic, we call it elevation. We'll discuss when we discuss ACS, ECG. But the most important thing which you should never miss is myocardial ischemia again. So acute coronary syndrome is represented by the ST segment, either in the form of elevation or depression. But apart from ST segment elevation caused by acute coronary syndrome, whether coronary artery disease or ischemia, another important element is potassium. Potassium causes ST segment and T wave changes. Because if you remember very well, potassium is one of the things that is responsible for, if you remember that plateau, which I mean the graph draw from for myocardium, phase 0, phase 1, phase 2, phase 3. So phase 2, phase 1 and phase 4, one of the most important electrolyte is usually potassium. So if there are changes in potassium as a result of either a shift to or from the cell, you'll see changes in the ECG, which is almost always represented in the ST segment region. There are other things that happen. The QRS can widen, the P wave can become flat, U wave can develop depending on whether it's hypo or hyperkalemia. But the thing you should never, ever, ever miss is MI, acute coronary syndrome, and electrolyte imbalance, especially potassium, and is usually represented in the ST segment, either in the form of depression or elevation. This is what I was telling you. It's called ST segment early repolarization. If you look here, somebody can say there is an ST segment elevation. And in reality, there is nothing, because this is the isoelectric line. I don't know if you're able to see. This is isoelectric line, and it's mostly seen in V4, V5, V1, V2. And it's very clear here. Look at this V2. If somebody sees this and comes with a chest pain, if the patient is 50 years of age, I'll get panic. But if the patient is a 20-year-old describing a very sharp chest pain, sudden onset, no risk factor, I see something like this, I will reassure, but still do a troponin. So this is called early repolarization and is a normal variant, very common in the young and especially in male. So I repeat the ST segment because they're a very important segment. Question number 1, what does it represent? Ventricular repolarization, the beginning of ventricular repolarization. What is the normal thing? It is usually isoelectric. You may have a very minimal elevation or depression, like in the context of early repolarization. What is the pathology? Elevation or depression. And what does it represent? It represents infarction, it represents ischemia, it represents electrolyte imbalance. The next wave we are discussing is the T wave, another important parameter. What does it represent? Ventricular repolarization, because the beginning of ventricular repolarization was represented by ST segment, but the actual repolarization happens at the T wave. What is the normal? T wave is generally speaking, positive and in the same direction as the corresponding QRS. So if QRS is looking up, usually T wave is also looking up. But there are some few exceptions. You may have some inverted T waves. As I told you, all the waves in AVR is always negative, including T wave. But you may see variable T waves. You may see sometimes some T wave inversion in some other leads, so on and so forth. But generally speaking, T wave is usually upright in all the leads, and it is the same direction as the QRS. So if QRS is negative, the T wave is usually negative. If it is positive, it's also positive. But overall, it is usually positive, number 1. It is not very tall and it's not short. It may be slightly taller than P wave, but there is no way T wave can be taller than the QRS. If you see a tall T wave that is even taller than the QRS, we call it tall peaked T wave. And it represents two important diseases, hyperkalemia and acute MI. Especially the beginning of MI, you may see only symmetrically tall peaked T wave. Okay? Now, if you see a sharply pointed symmetrical T wave, which is very tall, think of MI, especially if the patient has chest pain. But also don't forget potassium, because tall T wave is also caused by potassium. If you see if it's flattened, that means you cannot even see it, you barely see it, then hypokalemia is the cause. T-wave inversion is a very important representation of ischemia, which is different from MI. We will discuss those details later. But ischemia, generally, you can only have T-wave inversion. And it also represents one of the later stages of MI evolution. The first stage is T-wave, tall peak T-wave. The last stage is Q-wave and flattening of the T-wave, or the T-wave finally becomes inverted and it becomes positive later in the stage. So I go back to the T-wave. What does it represent? Ventricular repolarization. What is normal? It's usually upright in all the leads, although it can be variable, especially in the inferior leads. But generally speaking, it's in the same direction as the corresponding QRS. What are the pathologies? It can be tall, in which case it represents hyperkalemia and MI. It can be flat, in which case it represents hypokalemia, or it can be inverted, in which case it represents ischemia. Those are the three pathologies. The second last wave we are discussing is the QT interval. That's the right word, just like the way we had PR interval. You remember PR interval was represented atrial repolarization, atrial depolarization, and the electric flow up to the AV node. The same thing, QT interval is a combination of the repolarization and the depolarization of the left ventricle. In other words, the contraction and relaxation of the entire ventricle is represented by this interval. And it starts from the beginning of the QRS complex all the way to the end of the T interval, of the T wave. This is what we call the QT interval. Now, some few things about Q interval. Number one, you can look at an ECG very fast and say the QT interval is either short or prolonged. How do you know? If the T wave comes later than half of the, for example, you draw a line from the QRS all the way to the T wave. Therefore, if the T wave is coming or surpassing more than half of that duration, you can roughly say the QT interval is prolonged. But if you really want to sit down and calculate, there are several formulas which are used. The commonest formula which is used is called the Bazet's formula. And therefore, when you see at the ECG up there, they usually write QT, then there's a small c at the end. That c tells you corrected QT interval. Why do we call corrected? Because QT interval is affected by heart rate. So the formula was designed in such a way that you account or you correct for heart rate, because higher heart rate causes short QT interval, lower heart rate prolongs the QT interval. Why is the QT interval important? Because it is the area at which point the ventricle is vulnerable to arrhythmogenesis. There is something called QT phenomenon. So for example, there is something called refractory period. So if you remember that graph from physiology and Guyton's, that 0, 1, 4, those 4 stages, there is an area which the ventricle cannot be stimulated, whatever electricity comes. But there's an area which is also very vulnerable, so that if there's an electric message comes, it can degenerate into a very bad arrhythmia. So the QT interval, depending on the duration, there are those things that prolong the QT interval, and there are those that shorten. Whether it shortens or prolongs is a fertile ground for arrhythmogenesis. So drugs that prolong QT interval are more likely to lead a patient into arrhythmia. For example, hypomagnesemia prolongs QT interval. Hypokalemia prolongs QT interval, etc., etc. And when they prolong, you are making the ventricle vulnerable to being stimulated by an incoming stimuli, and therefore setting up a ground for an arrhythmia. We'll discuss this in more details. But in summary, the QT interval, what does it represent? The QT interval or the QT duration, it represents total ventricular re and depolarization. What is the normal? Usually for male and female, there is a big difference, but you usually have to calculate with a corrected QT, which you correct for heart rate. And there are 3 formulas which are used. The commonest one is Bazet, there's Fredericia, and there are other formulas, but just remember the Bazet formula. And whenever you are asked, why do you use that formula? You just say, we usually correct for heart rate because it's affected by heart rate and gender. But the figure to remember is 0.5 seconds, 4-5 seconds. Anything taller than that, we call it prolonged QT interval. Anything shorter than that, you call it short QT interval. This QT business is also very important because there are arrhythmias which are inherited, what you call inherited arrhythmias. For example, long QT syndrome, short QT syndrome, low QT syndrome. Some of them are inherited in the form of channelopathies, abnormalities in the channels of potassium, etc., etc. So EP studies, when they are doing, they study also the QT interval. And therefore, when you want to ablate a ventricular tachycardia, these are the areas you try to target and you ablate. In summary, it represents ventricular repolarization and depolarization. The normal is usually corrected according to age, sex, and according to heart rate. There are many formulas which are used. The commonest is Bazet's formula, but remember the value is 0.45. And this is what I was telling you. It can be prolonged, it can be shortened. The one which is important for you in MCQs is these drugs that prolong QT interval. There are very many, but there are simple ways of remembering them. For example, almost all antiarrhythmics, and you remember there was classification for classification of arrhythmias, class 1, 2, 3, and 4. So almost all antiarrhythmics, especially class 1 and class 3, they can prolong the QT interval. Almost a large number of antipsychotic drugs, they prolong QT interval. A good number of macrolides like azithromycin, clarithromycin, they prolong QT interval. So sometimes you can be given a long story of a patient who was treated for pneumonia, and they come with the following ECG. What do you think? One of the first things you ask yourself is pneumonia, antibiotic, maybe this guy was given azithromycin, let me look at the QT interval. Maybe they are asking you QT prolongation. Don't forget electrolytes. The best way to remember electrolytes is all hypos prolong, all hypers shorten. So hypokalemia, hypocalcemia, hypomagnesemia, whatever, hypo, they all, even hypothermia, all hypos prolong QT interval, all hypers shorten QT interval. And then the genetic mutations, this is what I was telling you, they are called LQTS, long QT syndrome, and there are very many, very many of them, Brugada syndrome, so on and so forth. Then finally, we have got the shortened QT interval, which is also caused by mutations. Also, we have the short QT syndromes, and we have got electrolytes, the hypers, hypercalcemia, hypermagnesemia, hypothermia, hyperkalemia, they all shorten QT interval. The last one, in the next 2 minutes, we are about to finish. We are supposed to finish at 8:30, is the U wave. Now, it can be a normal variant. I have seen a lot of ECGs, especially young people. When you look at the ECG, you'll see a small wave that comes after the T wave, but before P wave. So it's usually found between T and P. It's called U wave. It can be a normal variant. Nobody knows its causes, but people say that when repolarization is finishing, there is an influx of potassium into the cell, and that's what is responsible for it. That is why in the setting of hypokalemia, U wave becomes prominent. So the most important thing, it's a normal variant. It can be found in an ECG or not. It's not very important, but just remember it becomes very prominent in the context of hypokalemia, because the pathophysiology or the physiology responsible for U wave is thought to be potassium shifting into the cell the last time when the cell is repolarizing. And I think that brings me to the end of all the waves. So what I have done is I just wanted to take you through the waves, answering those 3 questions. What does the wave represent? What is the normal wave? And what is the abnormal? Now, this abnormal is an entire lecture on its own, pathology by pathology. And God willing, inshallah, every Thursday evening, if possible, we'll start discussing the pathologies one by one. We'll start with chamber enlargement because it's the easiest. We'll look at right atrial enlargement, left atrial enlargement, right ventricular hypertrophy, left ventricular hypertrophy. Then the next thing we'll go to is AV blocks, which is also somewhat similar. So those 2 topics probably we'll do the next Thursday. Then the other Thursday we'll do acute coronary syndrome, ACS in ECG. Once we are done with all those 3, 4, 2, I think we'll have 2 more sessions. Then we'll arrange with the organization so that we can meet physically and we can go all through one by one, and I'll bring some ECG examples. When we are discussing the next topics now is when I'll show you real ECGs so that it sticks in your mind very clearly. And I think I finish here. I open the forum for any question.
Thank you very much, Daktari. That was a very detailed and interesting session. We really thank you for this. We don't take it for granted. So to our audience, if you have any question, you can kindly unmute and ask in the interest of time, or you can put it down on in the chat box. We'll read it out to Daktari.
Good evening, Doc.
Good evening.
Thank you so much for the lecture. I'm seeking a clarification.
Yes.
On the issue of the axis deviation, you mentioned the circumstances when we will consult the lead 2, especially in left axis deviation. Can you please clarify there? Thank you.
Yeah, that's a very good question. So for right axis deviation, you only look at only one lead, that's lead 1. So that if lead 1 is negative, 100% you are sure there is right axis deviation. For left axis deviation, you first look at AVF. If AVF is negative, you need to confirm, because sometimes you may have a negative AVF while lead 2 and lead 3 are normal. Because lead 2, lead 3, and AVF are called inferior leads. They are called contiguous leads. They are leads which are neighboring each other, and they are looking at the lower part of the heart. So if AVF is negative, I really want to confirm whether this negativity is truly, truly negative, or is it just AVF peke yake? So I look at lead 2. If lead 2 is also negative, then I'm also 100% sure that this is left axis deviation. So for right axis deviation, there is no need for confirming. You just look at lead 1, negative, confirmed. But for left axis deviation, look at AVF. If it's negative, you look at lead 2. If it's also negative, then you confirm.
Thank you.
Thank you, Dr. We have a question. Does P mitrale present as widening or as like letter M?
So the letter M is not because it presents as M and therefore was named as mitrale. The letter M is because the left when the left atrium enlarges. So when you look at it, actually the first deflection, which represents the first hump of the M, is because of the stimulation of the right atrium. Now, when electricity leaves the right atrium, it's supposed to go to the left atrium very fast through some bundles, like the bundle of Kent. I don't know what there are 3 bundles. But what happens when the left atrium is enlarged, electricity takes time to cross all the way up to the left atrium. Hence, the P wave becomes wide. So the widening and the notching is because of the enlarged left atrium. But it was just coincidental that notching looks like M, and it was named as P mitrale. But the reason why it was named P mitrale is because most of the pathologies that causes left atrial enlargement is as a result of abnormalities of the mitral valve, whether it's regurgitation, whether it's stenosis, so on and so forth. And that's when you develop left atrial enlargement, hence the name P mitrale. But you're right, it gives a notched P wave. It's a wide, broad, notched P wave in lead 2. That's what you call P mitrale. But the mitrale is because of the pathology that causes the left atrial enlargement.
Thank you for that, Doc. There's another question. How do you place leads in a patient with dextrocardia?
So actually, by the way, let me tell you something. You can even put ECG leads on the back of a patient, so long as you know which lead is looking where. So you'll just place just the way you place on a normal patient. Of course, by the time you are diagnosing dextrocardia, this patient will have examined the point of maximal impulse in the right side of the chest, etc., etc. So even if you put the normal ECG the way it is, then you'll be able to know when you read the ECG that this patient already has dextrocardia, because the axis will change. There's something called R wave progression, because S in V1 is usually deep, while R in V5, V6 is usually tall. So this is usually reversed. So you will just put it the way you put on a normal patient, but when you are interpreting, you should interpret in the context of the patient. That this is a dextrocardia patient, most likely that's why these leads look like this. But as I told you, always you start with AVR. If you find AVR is overly positive, then there is a lead exchange probably. But Whether the patient is dextrocardia or levocardia, it doesn't matter. You just put ECG the way it's supposed to be put, but you interpret in the context of the position of the heart.
Thank you, Dr. I don't see any more questions in the chat box.
Yeah.
There was a suggestion, as I had told you, by the finalists. They'll want maybe just a focused session on the most common tested OSCE, ECGs, and all that. Maybe I had asked one of them to liaise with you. I don't know
I
if
got a text, I think, a bit later after we spoke with you. Unfortunately, I did not manage to answer. I was a bit busy in Kenyatta yesterday and the day before yesterday. Probably I will answer him and then we'll liaise with him and then focused session on basically specifically internal medicine, the areas to focus.
Okay, thank you so much, Dr. I really want to thank you on behalf of the audience and everyone who joined. For those who joined, also thank you so much for the participation. I think we'll
I'll share with you the slides so that once we are done with all the sessions, guys can have time to go through. And then at the end of all the sessions, I'll give you some very interesting, nice website where you can just get focused ECG. But as I mentioned in the earlier session, please feel free whenever you get an ECG, don't go to the pathology straight. Learn the normal first. Just take any ECG in the files on your own free time. Just go through what I've been telling you, the issue of like, for example, just rate rhythm axis. How does a normal ECG look like? There's individual waves, the way we discussed today. Start from the P wave. Is this what Dr. Hassan was telling us? How does this P wave look like? What is the PR interval? Then on top of the ECG gives its own interpretation. Then you can compare. You first hide it, then you can compare your interpretation with the ECG interpretation. Of course, you as the clinician is more important because you have listened to the patient history. The machine does not know the history. It will just tell you MI. But in reality, you need to interpret in the context of history, physical examination. By the time I'm sending a hypothyroidic patient to an ECG, I know what to expect. So I'll go straight to the ECG and I say, yeah, I have confirmed. Like, I'll give you an example. Yesterday, I was referred a young man, 25 years of age. He has this sharp pain, pleuritic in nature, etc., etc. Of course, he's very young. He did an ECG. He had widespread ST segment elevation. I was pretty sure this was pericarditis. So for confirmation, I sent him for an echo, and he had a small amount of pericardial effusion now, which ties all the picture. He had chest pain, ECG changes, and pericardial effusion. That's pericarditis. So by the time you have done your history, physical examination, and you are sending a patient for a test, you know what to expect. But before you reach there, please learn the normal. Just whether it's X-ray, whether it's BGA, whether it is ECG, just learn the normal. And the more you read the normal, the more you will be able to easily grasp the abnormal. Otherwise, I really also appreciate for taking time to listen. And inshallah, if there's any question, you can also save for next session. I'll share with you all the websites. Somebody's asking for the website. In fact, let me write the website. It's called, one of the most important thing I want you to go through is called Life in the Fast Lane. Fast Lane. Usually, I think the website is written like Life in, is it TFL? Something like that. Life in the Fast Lane. They have very, very, very nice ECGs, well summarized. They give you a bit of topics, then they give very many examples. So don't jump to pathologies. First learn the normal ECG, then the rest will come as time go by. Otherwise, thank you so much. Inshallah, have a good night, all of you guys.
Thank you, Dr. We'll end it here. Good night to all of you.
Shukran, Hassan.